Most students hear diarrhea and immediately think infection, but that's only part of the story and often not the right starting point. Diarrhea is not just an infection problem, it's a pattern recognition problem. And if you miss the pattern, you'll order unnecessary tests, miss inflammatory disease, or completely overlook malabsorption. In this video, I'll show you how to quickly rule out dangerous causes, the key patterns that narrow diarrhea in seconds, and the exact framework you can use for exams and OSCEs. Here at ScrubNotes, we approach every chief complaint the same way: safety first, then patterns, then key diagnostic forks. And diarrhea is one of the best examples of why this approach works. So let's dive in. When a patient says, "I have diarrhea," be careful not to jump to diagnosis too quickly. We want to start with safety. So our first job is to ask, could this be something dangerous? We want to screen for red flags like bloody stool, fever, severe abdominal pain, signs of dehydration, unintentional weight loss, and if they're in an immune-compromised state. If any of these are present, this changes our entire workup and approach. You're thinking stool studies, labs, imaging, not reassurance. And if not, then we move to pattern recognition, which is where we'd ask about duration, stool frequency, characteristics, any nighttime symptoms, recent travel or sick contacts, diet triggers, or any medications. Our clinical goal here is simple. We want to rule out dangerous causes before we diagnose the cause for diarrhea. So let's take an example case of a 32-year-old female whose chief complaint is diarrhea and see how this applies. Before narrowing anything, we want to start with broad differential list. Diarrhea falls into a few main categories. It could be life-threatening causes like severe infection, IBD, colitis, common causes like viral gastroenteritis, IBSD, functional diarrhea. It could be medication-related, such as antibiotics or laxatives, magnesium. There could be malabsorptive causes like lactose intolerance, celiac disease, or other food allergies. So the key idea here is not to make a long list. We just need to identify the pattern and figure out which bucket our patient fits into. And we can do that by asking focused history questions. So here's some general focus history questions I like to ask. First, I want to understand what kind of diarrhea they're having. Is it watery? That tells me it could be more secretory or osmotic. If it's fatty, greasy stools, I'm thinking more a malabsorption issue. And then if it's bloody, I'm thinking more of an inflammatory cause. We want to look at key pattern clues next. So if there's acute onset, infections are often the culprit. Chronic or gradual onset, maybe more functional or malabsorption. If there's nocturnal symptoms, I'm thinking more of an organic disease. And if there's fasting improves the symptoms, I'm thinking more osmotic issue. If fasting doesn't help, maybe more secretory. And then next I want to ask about defecation pattern clues. So if their pain is relieved with a bowel movement, that's more likely IBS. If there's large volume watery stools, it's maybe more secretory. And again, greasy foul smelling is more likely malabsorptive. Here's an algorithm I like to use to approach diarrhea. So I start with any red flags, checking for bloody stool, fever, severe pain, dehydration, unintentional weight loss. If any of those are true, then you're probably going to refer to more urgent assessments, so looking at stool studies, labs, and imaging. If no red flags are present, then I'm going to proceed to time course, because that's a really key distinguisher for us. So if there's acute onset for less than 2 weeks of diarrhea, I'm thinking of infectious causes. Maybe they had some recent travel and picked up a bug or around people who are sick. And even recent antibiotic use can cause that. Or if there's a chronic presentation of more than 4 weeks, then I'm going to start digging into the stool type. So if it's a fatty stool type, that's pretty classic for malabsorption. If there's bloody stool, more inflammatory cause, and watery, that's more likely a secretory or osmotic. And then we can dive even deeper into watery category, and we can ask if it's better with fasting. No, more likely secretory. If yes, more likely an osmotic cause. If there's any nocturnal symptoms, organic disease is probably the likely cause here. If not, that's more likely functional. And lastly, we could look at abdominal pain plus bowel movement presentation. So if they have pain with bowel movements, that's more likely IBSD. And we can also remember the Rome criteria, which is really only for chronic diarrhea, but there's some patterns here for you as reference. And then if they don't have pain with bowel movement, then it's more likely a functional cause. So now that we've asked focus history questions and have a systematic approach and checked for red flags, let's see how our case presents. We have a 32-year-old female with 5 days of diarrhea. She reports 6 to 8 loose bowel movements per day, described as watery but no blood. She endorses mild abdominal cramping but no severe pain. She denies fever, vomiting, or unintentional weight loss. She did recently return from travel and reports eating some street food. There's no recent antibiotic use, and she doesn't have any nocturnal symptoms. Now that we've gotten some focus history questions answered and applied our algorithm for pattern recognition, let's revisit our initial DDX list. So I think we've ruled out or lowered the likely cause of anything life-threatening happening here. I'm going to probably go with viral gastroenteritis as my working diagnosis, but I still want to keep inflammatory bowel disease flare in mind, and maybe malabsorption as well. In an OSCE exam, your goal is not to make the correct diagnosis, it's to support your working diagnosis and rule out dangerous causes. So our physical exam should be targeted, which our focus history has helped us do. Don't forget about vitals and general observations, but let's take a look here at some top DDXs in our table. If we were considering infectious diarrhea, we definitely want to do vitals and an abdominal exam. So if that was the case, we'd have fever, maybe some mild tenderness, no peritoneal signs. Let's say that it fits our current patient right now. Let's keep going. If we had inflammatory causes such as IBD or dysentery, again, abdominal exam is going to be our go-to. If those were the case, we'd probably see some tenderness, possible blood, and any perianal disease. If there was malabsorption present, our general observations, abdominal exam, but also skin, hair, and nails would be helpful because we'd look for signs of weight loss, maybe some nutrition deficiencies. So probably not likely in our case here. Next, if we have secretory diarrhea, again, abdominal exam is going to be important. We would probably see findings of mild bloating and otherwise normal. And lastly, if we were considering osmotic diarrhea, again, abdominal exam would probably be normal, but there'd also be no red flags. So based on our patient, looks like infectious diarrhea fits best right now. Okay, so it's time to bring everything together and present our assessment for this case. We have a 32-year-old female who presents with acute onset watery diarrhea for 5 days following recent travel. She has frequent loose stools without blood, mild cramping, and no systemic symptoms. Today, vital signs were showing mild tachycardia with signs of mild dehydration. Her abdominal exam is benign. This presentation is most consistent with acute infectious diarrhea, most likely traveler's diarrhea. Serious causes such as inflammatory or ischemic colitis are less likely given the absence of red flags. Before we wrap up, let's review 3 common traps students make so you can avoid them. Number 1 is not checking for red flag symptoms. So we want to check for bloody stools, fever, and severe pain. Number 2 is ignoring the stool type. Remember, not all diarrhea is the same. Watery, fatty, bloody, all have different causes. So pattern guides our diagnosis here. And third is skipping the time course. Sometimes students jump too early to treatment, so don't forget to ask about acute versus chronic, because time is helpful in our diagnostic fork. So let's summarize everything in our framework here for diarrhea. So remember, safety first. We want to rule out those dangerous causes. We want to use pattern recognition to help us, so time course, stool type, any triggers. Next, we want to check for key diagnostic forks. So if it's watery stool, we're thinking more osmotic or secretory cause. If it's fatty diarrhea, malabsorption is likely at play. And if it's bloody, that's pretty indicative of inflammatory. So diarrhea is not just an infection, it's a pattern-based diagnosis. I'm thinking of making a few of these into short packets, so maybe GI focus, neuro, or cardio. Let me know which would be most helpful for you. And if this video helped you, check out the rest of our Chief Complaint Series where we break down other presentations using the same system. And let me know in the comments what you'd like to have covered next. Thanks for watching.